All right, guys. So I wanted to go back and finish up Module 2. I planned on doing this tomorrow in class, but looks like we don't have class, so here we go. Celsius. We're going to work through some conversions here. Just want to go through this with you. I did it also on the end of Module 3. You will see that, but I wanted to put it here as well, okay, just for some more practice. So we're looking for the answer to 101.4 degrees Fahrenheit and how many degrees centigrade it is. So our math formula is for Fahrenheit, so 101.4, okay, minus 32 times 5/9. Okay, 101.4 minus 32 gives us an answer of 69.4 times 5/9. Okay, and again, because I've done this math so many times, I know that 5/9 equals 0.55. Whoop. Okay, so times 0.55, and we get our answer of 38.17 degrees. Okay, and again, we're going to take it back to our 10th position, so we're going to make it 38.2 degrees. Okay, so our answer is 38.2 degrees. Okay, here we have a question that gives us 38 degrees centigrade, and we want to know how many degrees Fahrenheit. Okay, so we're going to take our centigrade, 38 times 9/5. 9/5, for those of you with inquiring minds who want to know, always works out to 1.8. Okay, plus 32. Okay, so we have 38 times 1.8 in parentheses plus 32. 38 times 1.8 plus 32 is 100.4 degrees. Okay, I chose this question to show you 38.2 degrees is a full degree warmer than 38 degrees. Okay, so just keep that in mind as you're working through the conversion. Is almost a degree difference, okay, when you're working with things like that. All right, so here is our heart rate. We already talked about this a little bit. Okay, I'm going to just review for you real quick. Our really good pulses that we can count are our radial pulse, our carotid pulse, and our femoral pulses. Okay, all of the other ones are rather weak. We're not going to get great pulse points with them. Okay, and then we can also do an apical heart rate, which is here. Okay, and the apical heart rate is at the 5th intercostal space midclavicular line. Okay, we'll talk about that when we talk about the cardiac unit, but just know that that's one of the places you can assess it. Our normal heart range is 60 to 100 beats per minute, and again, I said some facilities say less than 90 is normal, but for my class, please know 60 to 100. Okay. All right, so here's our tachycardia, and greater than 90 or 100, depending on it. Okay, we talked about exercise. We talked about infection. Okay, fevers can cause this. Heart irregularities. Okay, drugs, meds, okay, all of those things can. Okay, bradycardia, that's our heart rate with a heart rate of less than 60. The heart rate is caused by meds, drugs, okay. A regular exerciser who's not exercising at the moment, okay, exerciser, okay, and irregular heart rhythms. Okay, so those are all of our causes of bradycardia. Here is an explanation quickly of what is meant of a regular versus an irregular heart rhythm or respirations. Okay, please note that the irregular ones are usually in varying amplitude, meaning some are stronger than others. Okay, so if we talk about a weak and thready pulse, this is what we mean. Okay, this is a weak and thready pulse. Sorry, my handwriting is awful on the computer. Okay, so weak and thready pulse. Okay. Our respiratory rate, again, another thing in the brain. Our normal respiratory rate is 12 to 20. Okay, you can choose to count either inspiration or expiration. Respiratory alterations we get with infection, brain injury, sedation, and drugs, right? Heard a great speaker again who talks about the importance of not making up or estimating the respiratory rate. So please remember to count that. Okay. So we talk on our math paper about, no, sorry guys, a pulse pressure. Okay, so our pulse pressure is our systolic minus our diastolic. Okay, so in this case, our 120 over 80 is 120 minus 80, and we get a pulse pressure of 40. For our hypertensive patient, we get 140 minus 90, and they have a pulse pressure of 50. Okay, I'm going to post a video because I'm concerned I still have to figure out what we're going to do with our quiz next week. So let me think about that, what we're going to do and how to accommodate that. Okay, these are all of our factors affecting blood pressure, our normal blood pressures. Okay, so orthostatic vital sign. We do orthostatic vital signs to assess for a change in blood pressure or heart rate with change of position. Okay, and there's my triangles again. Okay, and remember, triangles are change. Okay, so we assess orthostatic vital signs for a change in heart or in blood pressure or heart rate, okay, with a change in position. We lay the patient down flat in bed on their back, okay, for 5 to 10 minutes prior to the assessment. We then collect their heart rate and blood pressure while they're laying down, okay. We ask them to stand up, and then we retake their heart rate and blood pressure in a standing position. Most hospital systems include lying, sitting, and standing. Your textbook only talks about lying and standing, and I agree there's not a whole lot of difference. Sometimes you'll see markings in healthcare. Oh shoot, can't erase on the screen. Okay, you'll see markings like this. Okay, so this is the standing, the sitting, and the lying. So if we have a lying heart rate of 60 and a blood pressure of 120 over 80, and then we sit them up and we have a heart rate of 80 and a blood pressure of 110 over 70, and then we stand them up and we get a positive heart rate of 120 and we get a blood pressure of 90 over 40. Whew, we got a big change from here to here and here to here, and this is considered positive findings. Okay, so standing, lying, or standing, sitting, lying. Okay, our abnormal findings are any increase of a heart rate in more than 20, so this would be an irregular finding here too, a systolic increase greater than 20, or a diastolic decrease less than 10 or more than 10. Okay, so those are both abnormal, or the patient becomes dizzy or passes out. Okay, and with orthostatic vital signs, these are not the most stable patients, so please make sure that you're watching out for safety with this. Okay, so safety is huge. So if I were to ask you, as the nurse performing orthostatic vital signs, what would some of your concerns be? You would discuss with me the abnormal findings, and you would talk about safety of the patient. Okay, so our pulse ox readings, okay, I think we covered that pretty well. If you have any questions, let me know. Okay, so we're going to move on to some documentation in SBAR. When we talk about documentation, okay, first and foremost, it's a legal record, okay? I'm sure Dr. Crowther has talked to you about the legal record, okay? It is the legal proof that we did something or we didn't do something. Okay, there's this wonderful rule that says it's not charted, it's not done. That's a not. Okay, so this is the rule for documentation. If you didn't chart it, you didn't do it. Okay, so it's a legal record. It's also a running thread of the patient's care, right? It's also a record, okay, because we keep things in there like lab values and IV sites and what their assessment findings are, okay? So it's important first and foremost, First and foremost, it's important because it is that legal record, right? It's great as a reference point for us. So if we have a concern that there might be something that changed from our patient a while ago, pardon me. The touch screen is nice in many regards, not so nice in others. Okay, so it's a reference document, okay? It also works for billing purposes. Okay, and it helps us to basically keep track of what's going on with the patient, right? Okay, so when we talk about documentation formats, okay, we talk about flowcharts, and these basically look like Excel spreadsheets. Okay, there's a whole bunch of different flow sheets. You might have a flow sheet that talks about your assessment findings. You might have one that talks about intake and output. So how much did your patient drink and how much did they urinate out? Okay, all of those things fall in there. We have a narrative documentation note, which we're going to talk about in a little bit, okay? But basically this is just it's like a paragraph that we write about the patient, okay? And it gives us the free ability to write whatever we want, okay? Charting by exception means that you chart only the abnormals. Okay, so if there's nothing wrong with the patient, you wouldn't chart anything. Okay, some hospital systems do this. I highly discourage it because I don't know that it's going to cover you in a court of law. Discouraged. Okay, please. If it's the hospital policy and you want to follow it, that's fine, but do know that's putting you at risk, okay? Through school, I would really encourage you not to chart by exception. I would really encourage you to chart everything, okay? And our electronic health records, hopefully you got a good idea about that, okay? Basically, this is a computer database that keeps track of what's going on with the patient, right? Okay, so components of the medical record we talk about. We have our nursing admission and assessment. Okay, and every shift the nurse that comes on is required to do an assessment. Okay, so some nurses work 12-hour shifts, some nurses work 8-hour shifts, some nurses work 4-hour shifts. The rule is every shift you do an assessment. Okay, it also completes the history and physical of the patient, completed by the healthcare provider. So this would be by an MD, a DO, an NP, or a PA. Okay. And they talk about everything that has literally gone on with the patient since they were born. Okay, so when we talk a little later about our comprehensive health history, this is kind of what that is. It's a comprehensive health history. Okay, all right, so we have provider orders. So if the doctor's ordering breathing treatment, something like that, that goes under the provider orders. Our plan of care is what we are intending to do for the patient. Okay, the clinical pathway helps us to know exactly what it is that we need to do. So if the patient is admitted with pneumonia, a clinical pathway will give us a very specific set of guidelines that we need to draw blood cultures within 2 hours. We need to administer antibiotics. These antibiotics need to be administered. They're going to get breathing treatments this time. Okay. So that is completed in there. We have our flow sheets, which I already told you a little bit about. Okay. And we have our MAR. Okay. This is, oh, goodness gracious. Sorry about my screen. Okay. It's a medication administration record. Okay, so this is where when you give medication starting next semester, in clinicals, this is where it gets recorded. Okay, it will get recorded and it'll say, oh, I gave my patient 324 milligrams of aspirin at 8:04 in the morning. It will also contain any laboratory orders, so if we want to look at the patient's kidney function, we can look at that there. It also includes the results. Progress notes are the daily notes that the MDPA, daily notes, MDPA, NP, or DO update, okay? Consultations, these are extra doctors or PAs that are brought in to see the patient. So we might have cardiology, we might have pulmonology, we might have infectious disease. All of these people will come in and see the patients, okay? And then discharge and transfer summary. Okay, and that just basically helps us know what to do, how we're going to discharge the patient. And discharge starts at admission. How are we going to discharge them? Okay, are they going home? Are they going to a nursing home? Where are they going? Okay, your responsibility as the nurse, and this is for documentation. Okay, we have to adhere by HIPAA. Okay, maintain your confidentiality. So no leaving your computers open where people can see it. No leaving your notes where other people can see them. Okay, we want it to be accurate. Don't make up anything. Don't just pull together other pieces. It has to be accurate. So if you are documenting something, make sure that it's documented at the appropriate time that the information was collected. You want to make sure it's complete. So if you completed a full set of vitals, you want to make sure that your documentation reflects the complete vitals. Okay. We always want to make sure that there's a logical flow in organization so that someone else can follow our thought processes. Timeliness speaks to the fact that we need the documentation completed as close to the time it's completed as possible. So if we do a bed bath at 8:15, then we need to make sure that our documentation is as close to 8:15 as possible. Okay. Conciseness. Okay. Lots of people love to write big wordy notes. Okay. In healthcare, we are very concise and very short and very choppy. Okay. So some errors. Okay, this is a great test question, guys. Okay, so documentation errors. Okay, falsifying records, making something up. It's definitely a problem. I've seen nurses get in trouble for falsifying records a couple of times now, where they made up vitals and didn't do what they were supposed to do in terms of caring for the patient. So do not ever falsify records. Failing to note a change in condition. Okay. So a change in condition might be your patient is awake and alert one minute and the next minute they're not talking to you. You can't wake them up. They're sleepy. Okay, that's a change in condition. In addition to the change in condition, you have to note what you see, what your assessment is, who you notified, and you have to notify the doctor that you notified. Okay, and you have to notify, you have to write in your note, notified Amy Jackson, FNP, and your time would be 8:15 a.m. of change in condition, and then you want to know what the orders were that was received. Okay. Failing to document completely, so if you're leaving pieces out, that will get you in trouble. Performing an inadequate assessment is a big one that will cause you issues. Okay. Failing to follow the agency's standards or policies on documentation. So if your hospital policy says that you need to document vital signs every 1 hour, and Q is a 1 in nursing, okay, so vital signs every 1 hour, every 2 hour, vital signs every 4 hours, okay, anything like that, these are the policies that need to be followed in terms of your documentation. Do not ever chart in the future. You cannot chart something until it is done. Get it? Don't chart in the future. Okay, so narrative notes are great. Okay, they're really good for items when there really isn't just a box to check. Okay, some of our flow sheets, literally, you will check a box. Yep, done. Yep, done. Okay. But the narrative notes are for when we just need to put a little bit more information into it. So things that we record in narrative notes, conversations with the patient. Okay. So patient states that they're dizzy and lightheaded and they feel like they're going to pass out. Okay, that might not necessarily be captured in a little box that we check. Okay, so think about also conversations with the collaborative team, like that note that I just told you about here, that you notified me of a change in your patient's condition. Okay, that will be documented there as well. It's also really good for items that aren't on a flow sheet. Okay, so we talk about patient's hygiene status. Okay, I love talking about patient's hygiene, okay, because it really speaks to whether or not they can fully care for themselves at home. So that's another great thing that goes in there. Okay, so our narrative note writing on paper, we're going to begin with a date and a time, and we always tell time in military. Okay, so I happen to be recording this video right now on January 29th, 2019. Okay, I also happen to be writing it at what you now write as 2:42 p.m. Okay, in military time, you're going to add 12, so it becomes 14:42 for your time frame. Okay, we don't do A's and P's. Okay, it is simply 14:42. Okay, military time. If you have something that's written in military time and you want to know what it is in standard time, you can subtract 12 and you'll get 2:42. Okay, and then you'll be able to tell. So after noon, meaning 12 o'clock noon, everything goes to a 4-digit. Okay, prior to that, it's a 3-digit. Legibility does count. I have to be able to read it. Other care providers have to be able to read it. So make sure that you can read it. Okay, so this is probably not the best idea of legibility. Okay, so if I needed to rewrite that, I would do this and I would initial here. Okay, all right, so we document only in blue or black ink. Okay, we make sure that we are very much adhering to this because these are the only legal colors that we can use. I'm using the red pen here because it's easier for you to see, but in our narrative notes, it's only blue or black. So when you go to clinicals, this is what you need to have, blue or black pen. Okay. All right, no blank spaces, meaning you don't want to right here stop at the end of this line and then start here. Okay, so if we get to a spot where we think we need to start a new line, what we're going to do, we're going to draw a line all the way to the end, and then we'll start here. Okay, don't ever white anything out. Okay, we want to make sure that it's very transparent what it is that we're writing. Okay, so what we're going to do instead of no whiteout is we are going to cross it out. Okay, so we're going to cross it out with a single line, only one single line. Okay, one single line, and then you are going to initial it. Okay, okay. We're going to sign it. In order to sign it properly, you sign your name with your credentials. Okay, you are, at least for the moment, known as a student nurse. Okay, that is abbreviated SN after your signature. Okay, so when I was a student nurse, my name was Amy Jackson, SN. Okay. So when you sign your notes, you need to make sure that your name is signature, SN afterwards. You also need to make sure that you have a printed name on there as well, so that you know what it is. And then you also put your initials so that someone can say, oh, look, Amy made 2 mistakes on this document here. Okay, so again, you're going to sign your name with your credentials. Okay. All right. So focus on the facts. So only what's important. Please do not document, I listened to heart sounds. Please do not document, I heard this, or I saw this. Okay, we'll talk about this more in a minute. Okay, and we already talked about what we do for mistakes. Okay, so our electronic health record, just a little more information. It's a means of collecting and storing patient information. It can help to design the plan of care. It often has links to things like medication resources. So we'll talk about UpToDate, okay, or we'll talk about LexiComp. These are a number of different ideas or different databases that we can access to get information on disease processes and medications. Okay. So the benefits of the EHR, this is another great test question, guys. Okay, benefits of the EHR, benefits. Okay, so good things about it. It's very organized, right? Because the computer organizes it for you. It's legible. It is timely, right? Because it timestamps everything for you. It also has resources for you. All of the data is collected for you, or collated data. Okay, so like all of your vital signs are there and you can look for trends. Okay, so some drawbacks of the electronic health record, there just really is decreased patient contact with it, right? Because we're standing behind our computers. Okay, it does take a little, we lose patient connection, right? Okay, the other thing about it is it is, goodness, excuse me. I am so sorry, excuse me. It is time consuming. Okay. The other thing is there's an increased risk for HIPAA violations with it. Okay. Because people tend to leave their computers open. All right, so we have to talk about documentation a little bit. Okay, so I underlined Sentinel event so that I remember to talk to you guys about a Sentinel event. A Sentinel event is an avoidable incident. Okay, so if we can prevent something from happening, it's an avoidable incident. Okay, we want to make sure that we are doing everything in our power to avoid Sentinel incidents, right? They're bad. Okay, so when I worked at a hospital a couple of summers ago, they had a couple of Sentinel events where patients were very badly hurt and one died. Okay, so Sentinel events are bad. Okay, so when we talk about effective communication, we have to learn how to talk with each other. We have to know how to give a report. We have to know what information to include and what information to get back. Okay, so my reason in talking about Sentinel events is 65% of Sentinel events that happened in 2013 were the result of some sort of ineffective communication that happened. So let's talk about a few barriers that exist for effective communication. Okay, if we have a report that's given in an unstructured format, like there's not a logical flow, we don't know how to kind of keep up with it. Lack of standards and policies that says this is the hospital policy for reporting this information. Okay. Uncertainty about who's responsible. A lot of times you will have, when you get out into your clinical situation, you will have probably 3 or 4 different providers that are all involved in one patient's care. So it does get to be a challenge trying to figure out who is responsible for the information that your patient needs relayed. Hierarchy of relationships. As new nurses, y'all are probably a little bit leery and nervous about talking with advanced care providers like doctors, MDs, PAs, DOs. Okay, don't be. Okay, they're people. They put their hands on the same way you do. Make sure that you're able to have those conversations because really it boils down to patient safety. Differences in ethnic background. Okay, everybody has a slightly different way of communicating. I told you before I have a very dry sense of humor. It's my British background. Okay, it's an ethnic background. Not everybody understands that dry sense of humor. Okay, this happens also with different cultures where we might relay some sort of information in a different way. We might stand too close. We might talk too loud. Okay, these are all barriers to effective communication. Poor clinical decision-making skills. Okay, how is it that the nurse made the decision to do this, or the physician made the decision to do that? Okay, different communication styles. Nurses and doctors are educated differently. We have different communication styles, so we have to kind of put together this common format so we have a logical flow of how we're doing it, and it's an agreed upon way that we talk with one another. So when we do our crucial components, it has to be organized, complete, timely, concise, respectful, and positive nonverbal cues. So it doesn't help to stand there and talk to someone with your arms crossed. Okay. Who do nurses provide reports to? Oh my gosh, who don't they provide report to? Okay. So nurses, Okay, nurses provide reports to other nurses, to care providers, okay, so that's your doctors, MDs, nurse practitioners, okay. They also do PTOT, physical therapy and occupational therapy. You do transport. You might talk to someone in the lab that you give a report to. You might give report to your manager, okay, your nurse manager. We do not provide report to families, right? Because remember, report to, I'm sorry, my handwriting is awful here, guys. Okay. We do not provide report to families because that is a violation of HIPAA, right? Okay. Oh, I answered my question wrong. Okay, so who do we provide report to? Why do we provide report? Let's go back and do that. So I'm going to swap out these questions. So this one answers here. We're going to take this one and answer it down here. Okay, so who do we provide, why do we provide report? We provide report to improve patient outcomes, right? To ensure patient safety. Okay, that's the biggest one. To relay important communication. Okay, when do we provide reports? We provide reports at change of shift, change of care, when there's a change of condition. Okay, when the patient is moving care area, so change of care area. We also provide, no, I think that's probably about it. Sorry, I gave you an extra blank there. Okay, take a minute to watch this video by Z-Dog. He's a doctor out of Las Vegas. He's a very dry sense of humor, and he is a little bit, my purpose in putting this video here is he talks about the importance of SBAR. He is very good about his importance of SBAR. He tries to add in some of his humor. Some of you may or may not appreciate it. I can respect that. He's really not trying to be offensive. I think it's important to watch it because he does talk about that. So your link is here. So if you would load that in, it's a YouTube video. And I do realize it's a little culturally inappropriate and not so nice, but the bottom line message is good. So we take it, we look at what's positive about it, we spin it the way we need it, and then we move forward. Okay, so when we talk about SBAR reporting in our notes, okay, we talk about S is the situation. Okay, so what is going on right now with your patient? So what's going on? So my introduction is, this is Amy, and I'm calling from Ursuline, okay, and I'm calling about Betty Jones, and she's in bed 486, okay. The patient's code status is she's a full code. I'm calling because she's having difficulty breathing. Okay. Her vital signs are 120/80. Her pulse is 140. Her respiratory rate is 32. Her temperature rate is 98.7 degrees Fahrenheit. And her pulse ox is 86% on room air. I am concerned because she's having trouble breathing. Okay, that is all situation. So background, you can say she has a history background. Okay, she has a history of COPD. Okay, or she has a history of emphysema. Okay, she might have a history of coronary artery disease. CID is coronary artery disease. Okay. All of those things in there. Give this information. If it's a shortness of breath, I'm going to ask that you give it up there. Okay. Assessment. We actually want you to come right out and say what you think is wrong. Okay. So at this point in your careers, you're not going to have any idea what's wrong. You're just going to know something's wrong. Okay. I want you to eventually be able to tell me my patient is short of breath. And I want you to tell me that you are concerned that your patient might have a pneumo. Okay? Okay? Eventually. Okay? I am requesting that you are as a recommendation, and you want to request a chest x-ray for your patient. Okay? CXR is chest x-ray. And you want an order for some oxygen for your patient to be able to breathe better. Okay, and the doctor's going to say, great, thank you so much. I'm going to put in an order for a chest x-ray, and I'm going to ask you to put your patient on 4 liters nasal cannula of oxygen. Okay, so they have given you your orders back. You're going to say thank you, and you're going to read the orders back to them, and then you will document all of this in your notes. Okay. So now let's move on and write a sample narrative note here quickly. Okay. First, let's talk about quickly our narrative note rubric. Okay, this is a documentation piece. Okay, so when you turn this in, this will be stapled to the front of your assignment. I want you to write your name, okay, the system for which you're doing it. So the first one is on vital signs, so you'll write vital signs here. Next, date and time. Okay, I want it present in the correct format. Remember, that's the date and the time written in military point or military time. Okay, so for right now, it's 14:59. Okay. Orientation is alert and oriented times 4. We want to know if they're an accurate source. We'll talk about that more. We're looking for all of the appropriate information. An intervention is something we do to improve patient outcomes. Okay, anything that we can do. So we can provide education. This is my favorite one. I love education, if you can't tell. Okay, so provide patient education. You want to make sure that you get your signature on there, the legibility in blue and black ink. You want the formatting to be correct, and then it is worth a total of 5 points. Okay. All right. So let's write a sample narrative note here. I'm going to see if I can safely separate my keyboard here. Okay. So this is your narrative note documentation form. Okay, so it happens to be January 29th, 2019. January 29, 2019. Okay, and the time, which we know is worth points, is going to be, it's 3 p.m. now. I don't think you can see that on your screen, but what you're going to do is you're going to write 1500. Okay, so this is the date and the time. The next thing that you're going to write in your note is whether or not your patient is alert and oriented times 3. or times 4, excuse me, because that is part of your general survey. So you're going to ask your patient their name, their date of birth, where they are, what time it is, and then what the situation is. Okay, if your patient is able to answer all of those questions, you're going to write patient is A and O times 4. Okay, or if you really want to keep it simple, okay, I'm assuming that you're talking about patients, so you're gonna, whoa, oh boy, this is fun stuff today. Sorry guys. All right, so A and O times 4. Okay, the next thing that we're going to document in our note is a set of vital signs. So I'm going to just give you some vital signs. I'm going to tell you your patient is 36 degrees centigrade, oral temperature, okay? And again, remember when I taught you the vital signs, I taught you the very specific order that I want these to go in. Your patient has a heart rate of 80, okay? So you're going to write 80 heart rate. Your respiratory rate is 16, okay, 16 respiratory rate. I'm going to ask that you also at this point address their respiratory status. So what I will do is I will usually document ENL, and ENL equals even and non-labored, okay? That's hopefully what our patient's breathing status is, okay? Next, we're going to write their blood pressure. We're going to write 120/80. Okay. We're going to draw a line to the end. We're going to write manual blood pressure because a manual blood pressure is different than an automated blood pressure. And we're going to do manual beep. Whoop. Manual BP cuff. Okay, and please document which arm it is that you collected on. Okay, so you got it on the left arm. Okay, your patient's pulse ox is your patient's pulse ox is 96%. SpO subscript 2 on room air, okay, RA is room air. All right, next we need our pain. Your patient has 0 pain, so you can say 0 out of 10 VPS. Whoops. Oh boy, this is so much fun, guys. Sorry. This is why it's better to do this in class. All right. 0 out of 10 VPS, okay, 0 out of 10 verbal pain scale. Okay, we're going to pretend now that we're writing a little narrative note on our patient's respiratory status. Okay, so I'm just going to write patient upright in bed and NAD. Okay. NAD is no acute distress. Okay. Respiratory status improving. Okay. We might put in there that the patient is talking with a visitor at bedside. And please note that you are printing, not writing in cursive. Okay. Okay. Patient is talking with the visitor at bedside. Then I want you to list an intervention, okay? You don't have to write intervention here, but I want you to provide some sort of intervention. Usually it's education. So I'm just going to write here that patient was provided with information regarding breathing treatments. patient verbalized. You can abbreviate patient, PT. Patient verbalized understanding. And denies questions. Okay, so it's important that we verbalize, or we get the patient to verbalize that they understand and they didn't have any questions. Now what you're going to do is you are going to sign your note here, okay, at the end, okay. Okay, and we're going to draw a line all the way to the end. Okay, so date, time, ANO times 4. So this is 1 element, this is 2 elements. Your vital signs have to go in the right order. Okay. You write whatever it is that you need. You include your intervention here. Okay. This is really important. Okay, another place people go awry is the signature. Make sure that you sign. This is, if you guys can't read my writing here, sorry. This is my signature, A. Jackson, RN. Okay. When I come down here, this has to be filled out completely for you to get full points. So what you're going to do for your initials, you're going to write your initials. Okay. You're going to write your signature as it appears in the narrative note. Whoa, oh, please hold. Okay, so you'll write your signature here. Okay, and then you are going to print your name so that it is very clear to everybody who you are. Okay, and your credentials need to go here, here, and here. So for y'all, oops, for here, this is where you're going to write SN, okay? Okay, you're not RNs quite yet. You'll be soon. Keep swimming, right? Okay, so you're going to sign SN here, here, and at the end of your note. Okay? Have a great weekend, guys. I will look to see when I can reschedule our little vital signs thing for. Let me know if you have any questions. All right, take care. Stay warm.